All right, so let me go ahead and the camera, share the screen. All right, we're good to go. Okay. So in this conversation, I think it's a good place to start to talk about how is abnormality or how is abnormal psychology defined. Um, and what do we mean by it? Because if we look at abnormal psychology from a historical perspective, perceptions of abnormality have changed based on cultural changes within a society. Okay. If we look at, there's a saying that, um, and please don't take this as an insult if you're Christian or not. This it's not meant to be, but there's a saying that Jesus lives well in every mental health asylum. Okay, now let me break that statement down. Is if someone today would walk down the street and say, I have visions, I hear voices, I see things, um, and they profess themselves as the Son of God, owner of the kingdom of heaven, those types of statements. In today's modern world, very few people would go to his feet and start praying and happy that the second coming has come. Okay. Um, because those things are symptomology of abnormality today. Okay. However, if we rewind Western culture 2,000, 3,000 years ago, hearing voices, seeing things that were not actually seeable by other people, this manifest destiny that if a person feels that they are a king or a queen and whatnot, that it's divine interventions that are doing that was seen as normal. In fact, it was seen as elevating the individual to have those abilities and whatnot. And we can see through, again, Western history that there's this waning and gaining of this because we can look at the Greeks, we could look at the beginnings of Christianity, Judaism, where those kind of individuals were elevated. And then we get to the 13th through 16th hundreds, and well here in the United States into the 1700s of things like abnormality through witchcraft, and that people who have this ability to do spells and all these things were demonized, but not seen as holding something special. Okay. And again, speaking of the Western experience, if we look here in the United States during the time of just our Civil War period, the notion of ghosts and seeing things that other people can't see became part of normality. Indeed, Lincoln had weekly and monthly advisors that were, could speak to the dead and speak to ghosts and in his house. And there's actually a myth that the White House is still haunted by Lincoln today. And so we see that coming back into play in the US. And then we start getting the writings of Sigmund Freud. We get the talking cure. We go through what's called the chemical revolution of the 50s and 60s with antipsychotic drugs. And now again, this ability to see and hear things that no one else can see and hear, delusions of who you are and whatnot, is now again seen as a mental health issue. Okay. Um, and so we see this wane and fro throughout any culture about what is abnormality. Um, and again, when we do cross-cultural studies, we will see that there are still societies who hold individuals who in a Western medical society would see as someone who is schizophrenic or psychotic is held to a elevated status because they're able to see and hear things that no one else can see and hear. Okay. So just an example, of how things change within culture and how culture responds to things like what is considered abnormality. Okay. But we can break it down kind of into three separate areas. The first one is to define abnormality from what's called the egocentric perspective. Okay. And we will find this perspective very vibrant in individualistic cultures, as we will see when we return after Thanksgiving, where abnormality is seen as anything that I would not do or I would not see. So when I see someone, for example, fell, it's because they have a dispositional quality of failure. If we go back to the ultimate attribution errors that we often make in individualistic societies. So in this sense, abnormality, people who have mental illness, is anyone who deviates from my own psychology or my own behavior. Okay. And hence, children can be put into treatment and all these kinds of things to because a parent or a teacher thinks that the child has an abnormality. We've mentioned here in the class that the highest diagnosis rate of ADHD are children who are born in August and September. And reason being is because they tend to be the youngest children in the room. So the teacher is comparing that child to all the older children and see that they have more immature behaviors, less attention. And so they're more likely from their egocentric perspective of ADHD, say that that child has ADHD when it's probably their developmental period, not necessarily a disorder. Okay. And so that's the egocentric perspective. The other one is social norms. Okay. And probably the most salient social norm that determines someone who is mentally ill versus someone who is not in the United States. And I do need to put this as a social norm for the United States is criminally minded people that because they're deviating from social norms such as laws and rules, they must have a mental illness that is driving them to do that behavior. And probably one of the biggest debates right now is, for example, school shootings. And every time we see a school shootings, there's this re-vibration of we need to increase mental health services for the mentally ill because it's the mentally ill who are the ones who are doing all this destruction. Okay. Now, we will come back to that subject specifically because we need to note the difference between mental health and a mental illness. Because what we will find is that most individuals who do things like mass shootings, yes, they struggle with mental health, but they don't necessarily have a diagnosable mental illness. Okay. And we'll come back to that. But that's kind of an example of social norms. Another good example, um, um, another good example of social norms is we'll be talking here in a while about the Diagnostics and Statistical Manual for Mental Illness put out by the um, American Psychiatric Association. And what this manual does is it gives a list of symptoms and whatnot to allow a psychiatrist or a psychologist or a counselor to give someone a diagnosis. Okay. But one of the interesting things about the diagnostic manual is it's more designed on consensus than it is on statistical and behavioral information, on research. Okay. And probably the best example of this is homosexuality. Okay. I believe it was 1997 when we went from the DSM-3 to the DSM-4, all of a sudden homosexuality no longer was a disease or a disorder. Doesn't exist anymore. Okay. Um, but how did it get out of being considered a formal mental illness according to the DSM? Was not because of a collection of data that suggested that homosexuals were mentally healthy, socially engaged, could work, could function normally in a society, all of those things. No, it was based on a vote. Basically, the authors of the DSM said, yay to take it out or nay to leave it. Okay. And it was a vote that made it so that homosexuality was no longer considered a disorder as of, I believe, about 1997. Okay. And so that's another example of how social norms that change, the views of sexuality that started in especially the 70s, 80s, and it went into the 90s, that changed the perception of sexuality, then changed the social perception of things like homosexuality. Okay. And I use the term homosexuality because that's the term that was used in the DSM. So I'm not meaning that in any derogatory way. Okay. So that's examples of social norms and how social norms can play a role in determining if a person is mentally ill or if someone is mentally stable. Okay. Actually, and then we have culture. Okay. And how culture plays a role in the determination of mental illnesses. Okay. And again, I can go back to the witch hunts of the 14th, 15th, and 16th and 17th century. But I think a more clear example of how cultural influences here in the United States through the 19th and 20th century would be maybe a better example of how culture influences our perceptions of mental illness. Okay. If you recall Sigmund Freud, most of his patients were females. And the main diagnosis for individuals who were seeking mental health counseling or mental health assistance were women. And therefore, the main disorder was known as hysteria. Hysta is the Greek term for women's reproductive organs. Okay, so when you have a hysterectomy, it's the removal of the female reproductive organs. Okay, hysteria was thought to be caused by the female's reproductive organs wandering around the body and creating havoc within the female's body and creating this hysteria. That's where we get the word hysterical, comes from the diagnosis of hysteria, because they had hysterical symptoms, such as moments of anger, emotional outburst, uh, tantrum type behaviors, those types of behaviors. Okay. Now, how does this tie to culture? Especially during this period of time, the United States, and it still is, was very patriarchal. Okay. Meaning that for a woman to get health care, they had to either be admitted by their husband, or the hospital or the doctor had to get the husband's written consent to treat the wife or the woman. If it was a single female, it would be the father who would consent to the treatment of it. So you could imagine, in this cultural thing where men were considered the higher thinkers, the more intellectual, the more mentally stable, that when their spouse or their daughter started acting out, it was assumed that they did it because they have a disorder, a disease of some type that needs to be treated. So they would take the uh, uh, girl or spouse to the doctor and say she needs treatment. Okay. Now, again, this is where culture adjusts. Later on, research showed that the symptoms of quote unquote hysteria were actually equal between men and women. In fact, 2 out of the 3 studies actually found men to be slightly higher in the diagnosable component of hysteria than women. So again, as we see culture change from where we go through the women's liberation, women's change here in the United States, women's rights, as that progressed within the United States culture, the recognition that hysteria is not a female specific disorder became something that was researched, and it was found that men and women are equally able to get the symptoms of hysteria. Okay. So this is an example of culture and how culture can play a role in our perceptions of different disorders. And again, I hope you also see how when a culture changes, our social norms and our egocentric perspectives change as well. Okay. So as a researcher, and how the DSM is supposed to work is defining abnormality on a more measurable scale. Okay. So when doing research, for example, on things like depression and anxiety and whatnot, and we developed this what we call a beautiful little bell curve. Okay. A bell curve is a statistical assumption that if you measure something long enough, it will conform to what's called a bell curve, where the majority of people will measure in the middle range, and then people in this area, the more extreme areas, the less and less people will measure in those areas. Okay. And so if we look at this tell down here, so this would probably represent about 5% of people, and this would represent about 5% of people. So if this was on a scale from depression, represented by a D, to happiness, let's say they're antagonists with each other. If you're in clinical psychology, you would be interested in these individuals right here. If you study something called positive psychology that started in 1999, so it's relatively new here in the field of psychology, you'd be interested in this 5% right here and what makes them happier than the group here. And with clinical psychologists, what makes these individuals more susceptible to depression compared to, again, the mean or average individuals. Okay. So that's how, in a statistical way, we can view defining abnormal psychology. And we'll see that even within using strict statistical standards, these kind of things don't always apply. That sometimes even within clinical and positive psychology, we go back to these cultural and social norm standards to define something. Okay. All right. So I do want to start talking about how, in at least a Western culture, we define abnormal behavior. And I want to abnormal illness and whatnot. I do want to just make a note. I when I'm talking about clinical depression and whatnot, I tend to not use the word disorder. But I want everyone to know if I say mental illness, psychological disorder, or a mental disorder, those are interchangeable terms. Okay. I do prefer to use the word illness only because it makes that disorder synonymous with a physical illness, which it should be, and it should be seen as. Whereas when you use the word disorder, it just means that that person just needs to be straightened up and fixed up a little bit and they'll be fine. So I do have a preference for the word illness versus disorder, but I just wanted to clear myself on the language. Okay. And Bon, I'm going to get to your comment in just a minute because there's a concept that we need to discuss, which is really important. Thank you for that comment. So let's look at how mental illness is defined. Okay, if you look at this list of things, these are all things that we are likely to experience sometime in our lifetime. Okay. So while I hope the violence might have been when you were 3, 4 years old and you got mad at your siblings and you slapped them, that's the limits of violence. But we know it's not necessarily for a lot of people. We'll all experience forms of aggression, whether we be the aggressor or not the aggressor. We'll all experience some form of sadness. I think I've mentioned in this class all the time, we actually hallucinate every time we open up our eyes. But everyone in this class and everyone will someday hear a voice or a sound that no one else heard. Someday, if it's just once in your lifetime, you'll have a visual hallucination. Okay. Sometimes you will have an olfactory hallucination where you smell something that isn't there, that no one else can smell. Okay. Now, I am going to put a kind of warning label on the olfactory hallucination. If you start to smell bacon, and there's no bacon around, I would encourage you to get to the ER as quickly as possible. Because a very, very common, and it's kind of strange, a very, very common symptom of an aneurysm or a stroke is the hallucination of the smell of bacon. So there's a little bit of medical advice. If you start smelling bacon and there's no bacon around, I would encourage you to go to the ER. We will all have periods of irregular sleep. I think my last week, there's been one night that I slept 1 hour and another night that I slept 10. So it's going through some fluctuations. We'll all experience negative affect. Okay. We'll all experience some form of depression in our life, usually dealing with the loss of someone and whatnot. And we should look at this more closely when we get to things like treatment, because a person starts feeling depressed and instantly you need to go get put on medication, blah, blah, blah. But the truth behind depression is depression that everyone will experience usually will resolve itself within 90 days uh, for 90% of people. So there's this what we call the 90-90 rule. Most everyone will experience depression. For 90% of us, it will go away on its own within 90 days. If it doesn't, then the treatment becomes more and more important. If you've ever been to a buffet, you all know self-indulgence. There's very few people that I've come across that haven't had thoughts of harming themselves, elation, and I'll just get through these self-harm, anxious, scared, negative view towards others. These are all part of human experience. But when clinical psychologists in the Western area, oh, I put this one here. I'm going to come back to this. Well, we'll get back. Well, yeah, no, I better do this right now. Okay, and then I'll go back to those slides. But I think these are kind of out of order. The one thing that I do want to state before we get into this conversation about mental illnesses. If you are diagnosed with a mental illness and you are currently seeking treatment for it, based on these lectures, please don't stop taking your medication or stop treatment. This is an academic lecture. It's not a clinical lecture. But if you do see things that you might say, well, I don't know if I really have this disorder, please don't just change your diagnosis on your own. Go consult your care provider. So that's my caution and my warning as we get into these academic debates about mental illness. I would give the same exact warning if I was doing a academic lecture on physical illnesses as well. Okay, so I want to make that clear. So going back to that list of abnormal behaviors that we will all experience, what then makes a disorder or a mental illness? Okay. And this is kind of the three criteria. Okay. One, there's a cluster of those abnormal behaviors. Okay. So when you see those abnormal behaviors happening uh, with each other, then we get concerned because things like, for example, depression, low affect, sleeping issues, eating issues, motivational issues, those all cluster together and are occurring at the same time. Okay. And that these clusters of behaviors are deviant, meaning that they're not normal for you when you experience things like changes in sleep or changes in eating habits. It's something completely out of the normal, okay? It's distressful to you or to others, and it's causing you to feel like there is something seriously wrong with you, okay? And probably one of the most important is it's persistent over time, is that it's just not something that one week you have these symptoms and then the next 4 months you don't, and then you have them again. No, in those cases, what your counselor should be doing is they should be looking at your situation and your social condition to why you're having those symptoms on and off here and there. So the persistence over time is important, but probably the one that is considered most important, especially by clinicians and counselors, is that those clusters of abnormal behaviors are maladaptive, okay? Meaning that they're interrupting your ability to come to class, to work, to be active in social relationships. And so it's having this effect where you're not being adaptive to the needs of your world, to meeting your biological, psychological, and social obligations, as you would say. Okay. So this is, again, I'm going to put this in this um, guise, is that this is the Western conception of how someone is medically seen as having a mental illness. Okay. And the reason why I'm saying Western medical is that there's other ways that other cultures define the mentally ill or the mentally deficient, but this is the Western version of it. Okay. Now I do want to go back for just a minute because we did discuss it a little bit earlier, is the difference between mental health versus mental illness. Okay. Just like physical health, a person can have poor mental health, but no mental illness. Okay. So somebody could eat junk food all day long, drink all the sugar soda they want, but won't necessarily get diabetes. It puts them at a higher risk for sure, as the second bullet point points out. It definitely puts them at a higher risk, but it doesn't necessarily mean that they will end up with that mental illness, with a mental illness associated with that poor mental health. Okay. But let's talk about what is mental health, in how it can promote not developing a mental illness, just like good physical health can help promote not developing a physical disorder such as heart disease, cancers, um, um, uh, obesity, and diabetes. So let's go through these. Actually, I wanted to say something here as well. We always have to also remember the role of genetics in mental illness and physical health and physical illness. Okay. Because we're going to look at these dimensions of biology. And just like you could have the poorest mental health in the world and not get a mental illness, you could have the most perfect mental health. You can be the most physically healthy person, and you can still end up with a disease or a disorder. Okay. A good example of this is there was that health guru guy. He did that the Greatest Losers in the early 2000s, where they got people who were overweight and the one that lost the most weight, and they had these train. Anyways, that guy, considered one of the most physically healthy individuals, ended up having a heart attack. Okay. So just keep this in mind, that there is a lot more that goes into this, but having good physical health and good mental health is still our best tool to the experience of mental illness, or trying to not get one at all. Okay. So let's look at the dimensions. With physical and mental health, there's biological, psychological, and social dimensions of it. Okay. When we look at the biological, the ones that come to mind with physical health, of course, is a healthy diet, being active in exercise, and abstaining from toxins such as excessive alcohol drinking, excessive junk food, all those kinds of things. This should say in moderation, okay? So those are kind of the hallmarks of good physical health, okay? Mental health, we do need to include a healthy diet and exercise, but within and exercise, we need to include exercising our brain and mental capacities. So yes, this sounds cliche-ish, but this means engaging in crossword puzzles, problem-solving activities, all of those things. Those should be taken just as equally as important as physical exercise is. And just like biological abstaining from toxins for a healthy mental health, okay? On the psychological end, you will notice that there's some similarities too, okay? Physically healthy people tend to have what's called a growth mindset instead of a fixed mindset. Growth mindset is that I'm changeable, I'm improvable. A fixed mindset is because of who I am, I'm stuck where I am. This comes out of, for example, research done on IQ. There's people who strongly believe that IQ is set by your genetics and it's unchangeable. They tend to end up with poor mental health. And then there's individuals who say, I can get more intelligent, I can learn more, I can do that. They tend to have better mental health. Okay. Having healthy self-esteem and self-efficacy. Okay. When we think of this in the idea of physical health, healthy self-esteem is when you're exercising, you feel good about yourself exercising. When you eat a good, healthy lunch, you feel good about yourself for doing that. Okay. On self-efficacy, so self-esteem is this positive, negative evaluation of you, as we talked about a couple weeks ago in the personality section. Self-efficacy is the belief that you can accomplish something. This is different than growth mindset. Self-efficacy is the idea that I can go to the gym, I can fix healthy meals. It's more topic specific. Okay. Just like that, just like these with mental health, growth mindset that I can be with the IQ example, a healthy self-esteem, healthy self-efficacy that you can have control over your emotions and your relationships. And then thought engaging activities. And we did talk about personality traits, and one of the personality traits that tend to go hand in hand with mental health is open-mindedness, the ability to change your view based on new information. Okay. And then our social end. And after all, we are a social species. This is why we have cultures in the first place. Physically healthy people tend to engage in their social world and not avoid it. They engage in things like preventative and regular medical care. And just like that, with mental health, you'll see healthy relationships, engaging in preventative social activities and medical care. But with mental health, we see that on the social end, we have a healthy sense of identity, both our cultural identity and our individual identities. And we have a strong sense of belonging and place within our social world. And then, of course, we have healthy, intimate, and social relationships. So I wanted to bring this up as a conversation of, the parallels between physical health and mental health. But I did want to bring up the parallels. Just because someone has poor mental health may not mean that they have a mental illness that needs to be treated with serious medication or treatment. So I wanted to bring up those perspectives. And again, when we see individuals who do mass shootings, okay, they tend to not have healthy diets and exercise. They don't have a growth mindset and good self-esteem. But most important, the biggest predictor of a school shooting is a loss, a sense of identity, and a loss, a sense of belonging because of the rejection they perceive from their social world. Okay. That's not a mental illness, that's a mental health issue and a social issue. So just wanted to emphasize that point coming back from the beginning of this conversation. All right. I do want to talk about the role of trauma in both physical health and mental health. And when we talk about, well, let's define what's meant by trauma here in a minute, okay? Okay. So we're going to talk about trauma in the notion of what's called post-traumatic response symptoms, okay? And I'll just read the definition. Post-traumatic response symptoms occur as a reaction to experiencing or witnessing a traumatic event. The symptoms affect our emotions, psychological, physical function, and are often associated with the mental disorder illness of post-traumatic stress disorder. Okay. But again, I'm just going to bring this up. You can have symptoms, but unless those symptoms persist over time and become very maladaptive, that doesn't mean that there should be taken any less, but that doesn't mean that it has developed into the full disorder of post-traumatic stress disorder. Okay. Some of the common triggers, events are accidents, natural disasters, abuse, of course, combat, where we get the beginnings of post-traumatic stress disorder back in, for our country, we started to recognize it during the Civil War and World War I, where it became known as shell shock. And so this is where, again, I'll mention this is where a lot of the research on PTSD comes from, okay? I do want to mention for just a minute the difference between acute and chronic trauma. Acute trauma is, well, let me think. An example of acute trauma where I've worked with an individual is I had a student who after witnessing a car wreck, she was unable to drive. She would get near a car, grab the keys, and she would freeze, and she just could not bring herself. Now, she was not part of the car accident. She was a witness, okay? But what she did witness was a severe acute trauma during that exercise, not the exercise, during that accident. One of the individuals involved in the accident got decapitated and the head flew right in front of her car. Okay. And that caused these post-traumatic symptoms that she had. This is an example of acute. Okay. Now, I will tell you, we did a series of treatments with her. She did get over, I'm not going to say get over, but she managed her symptoms. She was able to drive. I will say that it took like 6 months to get her to that point. But that's an example of acute trauma and how it can affect someone. Okay. Chronic trauma is another form of trauma. You can think of this as a child who was molested, an adult who was in a series of violent relationships, and not only molested, but children who have high you know, negative life events in childhood. Okay, I can't remember what the name of it is. We'll get to it in a little while. Those are what we consider chronic traumas. Okay. And one thing that should be noted is based on the person's resiliency will determine the symptomology of someone who has an acute versus chronic thing. We find that individuals who have high resiliency factors, that acute or chronic trauma doesn't affect them as much. Okay. However, individuals who have low resiliency factors, and these aren't dispositional, this isn't about the quality of the person, and I want to make this very clear. Resiliency factors are not qualities of an individual. We'll get to these later, but I want to make this point, is that someone who experienced an acute trauma could have just as much trauma response as someone who has chronic trauma. Okay. The duration, trauma can last anywhere from weeks to months to years if untreated. Okay. Now, reason why I'm bringing this up, all right, is going back to our conversation about physical health and mental health. Okay. Is when a person breaks their leg, which is a physical trauma, they will always probably have scars even after that leg has healed. Okay. Same with trauma. When we go through trauma, we may be able to get through the trauma experience, but we'll always have those scars that make us more susceptible. So next time, if I break my leg, it's going to be harder to heal. Just like with mental health, trauma compounds itself. And the more and more trauma, the more and more scars we carry, the more difficult it is to make it so that the next time we experience that, it doesn't end up being something more chronic or more painful. Okay. And so I do want to go over some of the symptoms of post-traumatic response. As I mentioned, there's emotional, psychological, and behavioral. On the emotional end, it's the common symptoms are anxieties, depression, fears of helplessness, fear and helplessness, guilt and shame. And some of these are illogical. You probably have heard of the thing called survival guilt, survivor guilt, in where military people come back, or we can actually look at studies dealing with 9/11, where individuals have these clusters of emotional symptoms because they feel guilty that they survived. And I'll bring up the study of 9/11 right now to kind of emphasize this point, and then I'll talk about modern warfare and what we're seeing in post-traumatic stress symptoms and disorders. Okay, so when 9/11 happened, psychologists and mental health professionals assumed that the people who would have the highest rates of PTSD would be those who are closest to ground zero. Okay. But when we actually went and measured it, it was people who measured highest in post-traumatic stress and disorder were actually within a 100-mile radius of ground zero. Okay. And when we did further research, why is it that these people have higher rates of PTSD than those who were right there experiencing the trauma? Was largely due to these emotional symptoms. They felt helpless in the ability to help. They felt guilt and shame for not being able to be within 100 miles, but not have the ability to help or assist. Okay. And then comes the anxiety and the depression. Okay. When we look at modern warfare and we look at combat vets who are coming back from an active war zone, interestingly, the military personnel that are most likely to have PTSD disorders are not necessarily the ones who were in the actual combat zone. Interestingly, we're actually finding high rates of PTSD among drone pilots. We're finding high levels of PTSD among the gear in the rear military personnel because they are experiencing the trauma that is being created from a distance. And so they feel helpless, guilty, and shameful because they're not actively involved in that, but they're sitting there watching it. And for the drone flyers, the drone individuals, they are actually the one who is doing the damage from a distance. Okay. So, and again, when we look at, again, children who have been abused and whatnot, we find high rates of PTSD symptoms among siblings that didn't experience the molestation or the sexual abuse or even the physical abuse. But just purely being there and watching it, we're seeing slightly higher rates among the siblings than the individual who actually directly experienced the trauma. Okay. And it deals mostly with this emotional category of symptoms. This is where we see the highest quote unquote scores on these PTSD scales that we give. Okay. Psychological symptoms include intrusive thoughts and flashbacks, nightmare, and the two that are probably most prevalent, the intrusive thoughts and flashbacks tend to be situationally based when a person is triggered by some event. But what tends to be a continued psychological symptom is the notions of hypervigilance, meaning that they can't get their body out of the fight, flight, response mode, and difficulties focusing and concentrating on what's here because you're hypervigilantly looking for that trauma to occur again. Okay. So these two not only have an influence on our psychological abilities, but there are individuals who have experienced so much trauma that they cannot get their body out of the fight flight mode, and their body is actually physically wearing down because of that. Okay. And then the behavioral symptoms, often avoidance of reminders of triggers, irritability and aggression. Substance abuse is a very common behavioral symptom, and social withdrawal is another very common symptom of trauma. Okay. And so here's some things to think about when you experience a trauma or an effect in your life is experiencing these and then finding ways in healthy coping mechanisms to overcome these emotional, psychological, and behavioral symptoms. Okay. Now, of course, because we are a tribal college and we work with Native American populations, and we're part of that, it's important to consider unique traumas to Native American and Native American students, okay? And so I think I mentioned this in the class, the notion of historical trauma, okay? And I just want to read this definition. Historical trauma refers to the cumulative emotional, psychological wounds across generations caused by traumatic events experienced by groups. Okay. For the Native American population specifically, this includes things like colonization, forced removal, cultural suppression, and systematic discrimination. And one thing that I think needs to be included on this slide is genocide that occurred in many Native American communities. Okay. All of these past experiences become cumulative in a person's psychological makeup. When we talked about personality, we talked about the collective unconscious that was proposed by Carl Jung. And I mentioned that there's been recent studies where where there were actually genetic markers of one's trauma past before their birth. And again, I did caution. I said that those were single studies, replication needs to occur. But there seems to be this growing evidence that not only is trauma something that is in our collective mind, but it's something that is actually imprinted on genetic codes. Okay. This trauma often manifests with health challenges. There's some research that indicate that is showing that things like high rates of diabetes in Native American communities can partly, not all, partly be contributed by past traumas, loss of cultural identity, social economic struggles, and disruptions in the family and community structures. Okay. So when we look at certain populations, such as Native Americans, that have had in a very compressed period of time, and this is what makes historical trauma important to understand within the experience of Native Americans. For the majority of Native American history, they didn't experience this trauma for colonization, except within the last, how many years are we into this? 500, 600 years. Okay. So this trauma that is experienced by the Native American people has been compressed into a very short period of historical time, which has made it so it has had an imbalanced impact on Native Americans today. Because, and the reason why I bring this up is you can look at anybody's history, anyone's past, and you'll see some type of trauma. Okay. I come from German and Irish backgrounds, and I know in Ireland they were colonized, they were all that kind of stuff, but it happened over thousands of years. Didn't happen within a compressed 600 years. Okay. So it's kind of important to understand, yeah, everyone has historical trauma, but because of the times that are associated with it, it doesn't necessarily have the higher negative impacts that we see on individuals who have a compressed trauma past. Okay, so when we look, for example, within the African American community, that compressed period of time of things like slavery has had a historical traumatic effect on that population. People talk about the Jewish experience. Their trauma has occurred over thousands of years, but we are starting to see with our second and third generations that impact of the Holocaust and everything is now having an impact on Jewish populations from a trauma perspective. Okay. The other thing that we do need to note is that there's a compounding effect, meaning that the trauma severity, the experience of trauma symptoms, this is the sign for function, is a function of historical trauma, lived trauma, that's trauma you experience. So not only if you have, Native American historical trauma, but you were raised in an abusive home, abusive relationships, you've had severe accidents, maybe a combat vet, all of those things are what we call lived trauma. And then the factor of resiliency, okay? Resiliency being those coping skills and abilities to understand your trauma and how it impacts your life. Okay. Okay. So this is this part that is important to talk about. And we'll just end with, let me see, we'll end with this today. Well, yeah. And then we'll get into Western diagnosis of mental illnesses when we return. And then we'll do some comparative cross-cultural studies with certain disorders to see if they have cross-cultural variants. But I do want to end with this, considering of Native American, this specifically to students. These are 4 things that are common in the literature that can help culture responsive education, what we're trying to do here at TOCC, trauma-informed practices, but within our community, community engagement, and promoting resiliency are all things that we can actively do as communities to kind of help or work with this thing we call historical trauma. Okay. All right, I'm going to stop here. Let me hold on just a second. Let me stop our recording.